Good morning. Today I'm going to tell you the story about menopausal hormone therapy, how it came to be, what we learned from the past, mistakes that we've made, where we are now, and the current recommendations that you can use with your patients. I've been caring for midlife women for many years, and when I became credentialed, maybe some of you in the room had just completed your puberty, so you're going to have to trust me on the story that I tell. So it all started with the matriarch of menopausal hormone therapy, which is Premarin. That's conjugated equine estrogen. Born in 1942, it was the primary estrogen that was used. It dominated the scene up until the 60s and 70s. Its use in the 60s and 70s was really considered as a replacement for deficiency of estrogen in hormonal women. And actually, Dr. Wilson's book, Feminine Forever, he was advocating, as were others at the time, a way to keep women feminine forever by taking estrogen. And a quote from his book is that it can be used to cure the tragedy of menopause. So, about mid-70s, we really discovered a tragedy, and that was using Premarin or estrogen alone increased the risk of endometrial cancer. So we had to add a progestogen, Papa Provera, which is medroxyprogesterone acetate, which is a synthetic progestin, to negate the risk of endometrial cancer. And in the beginning, like beginning of many partnerships, there were some hiccups along the way. When we were using estrogen and progesterone, Premarin and Provera, in a cyclic, sequential schedule with a hormone-free interval, we brought back the tragedy of menses. So women started having cyclic bleeding, and they weren't going to tolerate this. So it led to a little bit of tweaking with some adjustments, and now we use continuous combined estrogen progesterone daily, which caused amenorrhea, which we went from tragedy of menses to the victory of amenorrhea. Also at the time, around that time, we were starting to advocate estrogen and progesterone to reduce the risk of chronic diseases. If you can reduce the risk of endometrial cancer, are there other cancers or other diseases that we could prevent? Thus, that led to the WHI. We did have some data from observational studies at the time saying that it could reduce cardiovascular risk. Well, this led to the WHI study. Dr. Medella referenced it. It was a randomized controlled placebo trial. The primary endpoint was the prevention of chronic diseases, cardiovascular disease, stroke, VTE, breast cancer, osteoporosis. In retrospect, it ended up being a tragedy again. As Dr. Medella mentioned, the wrong population, I think, was chosen. The average age of women in that study were 63, which is greater than 10 years past that final menstrual period. And perhaps it was the wrong formulation. The E+P arm was stopped prematurely about 6 years after it started because of the elevated risks of those chronic diseases that we noted. The Premarin-only arm was stopped after about 8 years. There were some benefits we found, reduction in the risk of osteoporosis, maybe colon cancer, but overall, the risks were outweighed the benefits. The biggest tragedy, I think, was the media blitz that occurred. So the media released the information and the announcement about the risks before any of the professional medical organizations had a chance to prepare the medical community, prepare patients. And actually, they released the information a week before the actual study appeared in JAMA. So then the media also emphasized the relative risks of these diseases, which seemed exaggerated compared to the absolute low risks in the study. So talk about fake news. Anyway, women stopped using their hormones, and prescribers stopped prescribing. So where are we now? Well, over time, we did follow those women out for 13 years, and we reevaluated the data, scrutinized the data from the WHI, and reorganized it into age stratification. And as Dr. Medella said, very important, there is a window of opportunity, time-wise, where women can take menopausal hormone therapy where the benefits outweigh the risks. And that's between the ages of 50 and 59, or within 10 years of the onset of menopause. And when we looked at those women in that age group, they really had little to no risk and actually had a decreased mortality from all causes. So the contraindications to menopausal hormone therapy are the same. All those chronic diseases that we were studying, if a woman has those active or a history of, then we need not to use menopausal hormone therapy. We've also narrowed our focus for indications. So the indications are severe vasomotor symptoms that interfere with life and sleep. As Dr. Medella, sleep's very important, leads to decreased mood and brain fog. We can use menopausal hormone therapy for prevention of osteoporosis and treatment of Genitourinary Syndrome of Menopause, GSM, which is the vaginal atrophy, the painful intercourse, and those bothersome urinary symptoms. We've also focused our indications in terms of patients, and we've also focused it in terms of formulation. We now are recommending a new generation of menopausal hormones. Specifically, I call them body identical, meaning they're the same hormones that are produced by our body, and that's 17-beta estradiol, which comes orally and transdermal, and a gel and a spray, and we use oral micronized progesterone, which is a nightly tablet. Please tell your patients, bioidentical is not a medical term, it has no medical meaning, it's a marketing term, and it doesn't mean that the medications are safer or more natural. I tell my patients there is no estrogen tree. All of these hormones are synthesized or made in a lab. So the other key takeaways from the history that we've gone through is there's no limit to the duration of use. Initially, after the WHI, people were saying no more than 5 years. Can't use hormones no more than 5 years. Well, that's not true any longer. What I do is reevaluate when that woman ages up to that next decade. We reevaluate their risks, their individual medical risks, their family risks, their goals, and their specific symptoms. We can be flexible as they age up. We can offer a lower dose. We can switch them to transdermal if they have been taking oral. I mean, there are some exceptions to the transdermal use, but in general, we try to have women use transdermal. Vasomotor symptoms do decrease over time for most women, not all, but for most women. And so if that's the case, then we can transition to vaginal estrogen, which is local, extremely safe, very effective for GSM, and you can use it for as long as you like, and you do not have to add a progestin to oppose it. So in summary, I would say choose the right patient at the right time for the right reason and the right formulation. Individualize each patient, use shared decision-making to come up with, again, based on the woman's goals. And I know this story will be continued. If you'd like to find more resources, the Menopause Society, that's formerly the North American Menopause Society, it's very scientific, it's been around for a long time. Dr. Lauren Stryker, I particularly like some of her stuff that she does separate from the Menopause Society, but she's a Chicago OBGYN. Dr. Jen Gunter is a Canadian OBGYN, and she has a blog called The Vagenda, and she's very witty. And then from the more internal medicine endocrinology point of view is Dr. Anise M. She's a endocrinologist from the UK. That's my story.
Great. Right, so I'm going to talk about menopause impact on hormonal health and how that can affect libido. And I'm excited to talk about this, but I never in my wildest dreams thought I'd be on stage talking about this. I spent all of my 20s thinking, God is calling me to the mission field. And so for 10 years of my life, I got ready to go to Africa. And that didn't happen, clearly. Instead, I ended up in Gloucester, which is also wonderful. I love Gloucester, but I arrived there and I'm like, I'm prepared for a lot, but my average patient's like late 40s, early 50s, kind of the exact patient Dr. Medella put up, complaining of perimenopausal and postmenopausal concerns. And I'm thinking, I am not prepared to deal with like the hormone health and certainly not sexual health complaints. And these ladies are telling me everything. So I started thinking, okay, I need to get some education. So I started reading. I got menopause certified. I followed in Dr. C's footsteps. And then I keep, just listening to my patients and seeing what are the concerns in this period of their life, what's working for them, what's not. So today I just want to share some practical tools for you about the two most common complaints I hear: decreased libido and GSM, painful intercourse. So we're going to talk about that. So one concept I think is interesting, we get to see women over the span of their life. We get to see in their 20s, 30s, 40s, beyond. And there's a concept that people have studied across multiple cultures and multiple socioeconomic. In your early 20s, you're pretty happy. You have good health, you have good friendships, you don't have a lot of money, but you're optimistic. The future is going to get better. And then unfortunately, it kind of goes down, down, down to 47 is kind of a low point of happiness because of all the things we mentioned: work stress, family stress. Then your hormones start going crazy. This is where the patients come in are like, doctor, check all of my hormones. And like 98% want to lose weight. And a good handful are also in there saying, I don't want to be intimate with my husband anymore, and so you have to have practical things to help people. The good news here is it does recover, but we want to have tips to help them recover quickly out of that. We don't want to leave them down in the valley. So, sorry. So anyway, I'm going to talk about decreased libido. This does tend to hit, it can hit at any point, but yes, particularly the late 40s. That's when we hear a lot of decreased libido. And we know it's multifactorial. We know that women, when their cortisol's high, their libido's really low. And they say, I have 1,000 things on my to-do list. Having sex with my husband is not at the top. So I'll say, the husbands could take something off your list and move it up. But there are multiple things that go into this. They're starting to put more weight around the midsection. They're feeling like their body's not working for them. Their testosterone, we can check their testosterone. Their testosterone at 47 is not going to be at what it was at 27. Like, it declines over the course of time. I think the best thing we can do for our patients is just, again, be comfortable having that discussion. And they're not always coming to you just for a pill. It's not like, have an ill, take a pill. Like, they want wisdom from you. They want guidance from you. So when you look over their medication list and you see Prozac, you can say, oh, I see you started Prozac 6 months ago. Did you know that could decrease your libido, make it hard to orgasm? And they're going to say, nobody told me that. And I'm sure you all did tell them that. But, then you can say, would you, have you thought about transitioning to something else or weaning off of that? You can tell them things like, I know you're having some relationship issues you were sharing with me. Instead of just saying, go to relationship counseling, you can say, well, here's a website, marriagebuilders.com, because it is very important to keep novelty in the relationship, in the bedroom, out of the bedroom. And so you want to direct them to practical resources they can use. And there are actually some websites now, cognitive behavioral therapy. There's a website, esense.health, that ladies can do cognitive behavioral therapy for 3 months. And that improved libido 87%. I mean, that's impressive. That's way better than medications. It's also important, too, to talk to them about, be comfortable talking about their bodies, and things like orgasms. So Dr. Casanova, at the beginning of this, she said she taught sexual health to the young children. So I feel a little bad saying this, but in this country, the sexual health is basically, here's your anatomy, here's what to do not to get pregnant and not to get an STI. But a lot of women are not educated about their body. They're not educated about orgasms. You know, studies say about 15% can't orgasm, about 50% have difficulty, and so they're going to come into you for help with that. And again, many ways to enjoy the experience, but certainly if they're seeking help with that, you want to have a resource for them, more than just, oh, go try to masturbate, you know? So you can refer them to a website. It's called omgyes.com. It's not pornography. Again, it's evidence-based, where they can subscribe for $80. They can watch videos with their partner, and it has, you know, tips on increasing intimacy and also tips on instructional videos. So again, you can refer them to something they can do in the comfort of their home with their partner, which can help their libido. There are medications that are approved. People were waiting long time for female hypoactive sexual disorder medication. So in 2015, the FDA approved Addyi. It's a daily pill you take at bedtime. You can't drink any alcohol around it, or you might get hypotensive. Insurance coverage varies. It can be up to $1,000 a month. It leads to 1/2 to 1 more sexually satisfying encounter per month. So there's also an injectable medication, Vyleesi, that can increase desire. About 25% of people respond to that. Again, I talk to patients about it. I haven't seen a lot of success, to be honest, in practice. The million-dollar question, though, is, will the hormones make my sex life better? And so we get that question a lot, you know, and certainly if it's GSM and they're having painful intercourse, you know, absolutely that's going to make things better for them. But again, as alluded to here, it's never going to be FDA, like, take the systemic hormone therapy. I should never say never, but, you know, it's more that if they're taking hormone therapy, their mood's better, their sleep's better, their energy's better, their joint pain's better. Of course, that's going to make them want to be more intimate with their partner. And that's why you get the ladies in their late 70s, early 80s that are like, do not take my hormone therapy away. So, you know, hormone therapy for that reason I think does help with libido. We also get asked about testosterone, and you might be surprised to know that ACOG and the Menopause Society have released statements about this, saying it can be used in women. Of course, it's off-label, but it can be used in the context of shared decision-making, excluding other causes. If you are going to use it, you want to make sure you monitor levels. You want to make sure you counsel patients about possible side effects, deepening of the voice, clitoromegaly, increased libido for everybody. I've seen that. So you have to really watch that, watch their levels. You can use 1/10 of the male packets of androgel, or you can also get it compounded from Williamsburg Drug Company. You do want to give estradiol, replace that, because you don't want to give them unopposed testosterone and increase the risk of atherosclerosis. We don't recommend pellets because it can be very difficult to remove the pellets. And so I was alluding to before, I've had several patients come from outside clinics that have done pellets and come to me with problems, bleeding, too high libido, deepening of the voice, and you can't reverse those pellets easily. So you do have to be cautious with it. And that leads right into the next part. So we see a lot of decreased libido in the 40s, and then we get into the 50s, and usually 3 to 5 years after menopause, people start getting pretty significant GSM symptoms. And it can show up in a wide variety of ways, but studies show it can be in up to 80% of women, and it's, you know, chronic. It does progress unless it's treated. So the most important thing you can counsel them is education, you know, and say, I know you want to be intimate with your husband in this way, but, you know, the vaginal tissue is elastic. It has to be stretched once or twice a week. And, you know, that will bring more blood flow to the area, more elasticity to the area. And sometimes they have to go buy medical grade vaginal dilators on Amazon. I still remember telling my office manager, I want to stock vaginal dilators in the office. She's like, no, they have to get that on Amazon. But, you know, physical therapists also can help with this as well. But some ladies don't necessarily want to see a physical therapist. They want to do this in the privacy of their home. But you do have to talk to them about at least once or twice a week It's important for that. There are different kinds of lubricants out there. A lot of patients start with KY jelly, but things like Uberlube is a silicone-based lubricant. You can go on the website, you can get samples. I'm giving them out multiple times a day to patients because it lasts longer than KY jelly, and it seems to be better for the postmenopausal tissue, from what I've heard from the patients. There's also a wide variety of products for vaginal dryness out there. Coconut oil is a good natural moisturizer or lubricant. A lot of patients use that. There's Reverie, which is hydrouronic acid. There's vitamin E, Luvina and Replen, so a lot of products for dryness. If the patients want to go straight to a prescription, they're very symptomatic, they want to go straight to a prescription, that's certainly fine too. So all varieties of estrogen, tablets, creams, rings, suppositories, vaginal DHEAS or Intrarosa, an oral pill, if they don't want to put anything down there, an oral pill they can take every day that will help. The other thing you might not be aware of is, even after you fix the dryness issues and some of the GSM, with natural aging, I have patients come in and say, things just don't feel right down there on the outside. There are structural changes to the vulva that happen over time, and patients can have decreased sensitivity, which again leads to difficulty with orgasms. So, again, not FDA approved, but I've heard good success. The Williamsburg Drug Company does make a compounded scream cream for the patients that has testosterone, Viagra, L-arginine that vasodilates and increases sensitivity. So again, if you've just more tools in your tool belt, okay, when the patients come back in and they're like, I really need help. I've tried this, I've tried that, I want to try something else. So I never thought I would say those words on stage in my whole life, but it has been helpful for the patients. So the main thing here is really just reading the practice pearls. Dr. Haver wrote a book about 2 years ago, The New Menopause. It's an excellent book. A patient told me about it. It's a New York Times bestseller. She has a website, The Pause Life. Again, that omgyes.com if they're want to increase their intimacy with their partner. esense.health, that's a cognitive behavioral therapy for low libido. Marriagebuilders.com is, again, practical relationship advice. And then the Uberlube if you want to get some samples in your office. So anyway, I think sexual health is an important part of women's health. We really want to help patients, empower them, and make them confident, through all decades of their life.